बिस्मिल्लाहिर्रहमानिर्रहीम। इय्याका नअबुदु व इय्याका नस्तईन। अल्लाहुम्मा सल्लि अला मुहम्मदिन व अला आलि मुहम्मदिन व बारिक सल्लल्लाहु व sallu ala. Dear colleague, I am Dr. Sultan Ayub, working as a radiologist. This is female, 45 year age, with history of lump in the right breast. So I am going to scan the right breast. So on clinical examination, I have seen that the nipple is retracted, and also she is giving history of discharge from the nipple for the last 1 year. History is for the last 1 year. So this is the right breast, and we can appreciate this irregular shaped mass, which is hypoechoic predominantly and is of mixed echogenicity. We can appreciate the irregular speculated margin. So mass is irregular in shape, hypoechoic predominantly, and this mass is having at the periphery speculated margins. However, we can't appreciate any calcification, and here we can appreciate this is the tubular structure which is entering into the mass. So this mass is obstructing. This is a duct we can see on the color. So this is a dilated duct which has been obstructed by this mass, and this mass is present at the seminocular position and also extended to the echotexture position. So I'm going to put the color. What is the vascularity of this mass? Here we can appreciate that mass has arterial as well as venous blood flow. We check the here look at the velocity of the mass, which is almost 10 to 11 centimeter, and the diastolic component is also significant. So we have seen that what the findings are: the irregular shape with speculated margin, mixed echogenicity, predominantly hypoechoic mass is seen at the seminocular position extended to the echotexture position, that is obstructing the duct and showing significant vascularity with arterial and venous flow, and look at the acoustic shadowing at the periphery at the margin, while it is giving enhancement at its mid portion. So periphery it is showing posterior shadowing at the periphery. So this is all about the mass. And now I'm going to scan the axilla, and this is the we can appreciate the lymph node within the axilla. Look here, this one. This is also present. This is also present. So we what I have seen that this lymph node is showing significant cortical thickening. From here to here is the cortex, and this tiny structure, this one is the fatty hilum. So there is a thickening of cortex, and this has another lymph node is this. And so these are significant bulky lymph node. We see the vascularity. So arterial blood flow is also seen. So multiple lymph nodes are seen at the right axilla with significant cortical thickness. So now I'm going to scan the look here. This is a dilated duct which is entering into the mass. So this mass is obstructing the duct, and this mass is irregular borders, and also the peripheral acoustic shadowing. So now I'm going to scan the abdomen. Here we can appreciate the look here, the ascites is present. It means that the mass has involved the peritoneum. So here we can appreciate this one, this area. This is the omentum, which is also thickened and heterogeneous. This is this all is the omentum, and these are the gut root which are normal looking. And this is the omentum, this one, which is thickened, heterogeneous. So now I'm going to scan the other organs of the abdomen with the low frequency probe. Here we can appreciate this is the liver, left lobe of the liver, and we can appreciate multiple target appearing lesion diffusely involving the left lobe. And this is the portal vein, this one, which seems to be patent. But we cannot appreciate the a little bit flow is present within the portal vein. It means that somewhat portal hypertension is present. I'm going to see the velocity, which is 3.8 centimeter. So left lobe is diffusely involved by the target lesions. This is the right lobe, which is also showing diffuse involvement with target appearing lesions. So multiple lesions are present in both lobes, right and left lobe. Ascites is not present. Sorry, periphery, this is the diaphragm and this is the right CP recess, costophrenic recess. No periphery is seen. And this is the left CP recess, no perfusion. Kidneys are normal looking. So in conclusion, we can say that there is a right breast mass which is likely to be the malignant with hepatic metastasis and peritoneal carcinomatosis. Peritoneal metastasis, sorry. So what should be the, I will put this breast lesion to the BI-RADS 5 category, which shows that almost 95% lesion seems to be the malignant. So this patient should go for the histopathology, core biopsy, core needle biopsy, and further management. Also the CT chest should be done with IV contrast, see any metastasis to the lung, because the most common site for the breast lesions, the metastasis from the malignant lesion of the breast goes to the lungs, liver, and bones. These are the common places: lung, liver, bone. So this is the main culprits we have seen. So this was all about the case, which we can say that the right irregular shape with speculated margin breast mass showing vascularity on the color Doppler scan with hepatic metastasis and peritoneal metastasis. Likely by rat 5 on the sonographic sonographically. We should go for also the mammography and the CT chest with IV contrast. The most common in this presentation would be the papillary carcinoma or invasive ductal carcinoma, which is obstructing the duct. And this would be diagnosed on the histopathology. Thank you very much.